we are very much thankful to Dr. Ketan Patel. He is traveling by car for an emergency operation on a neurological patient, but still he is so much willing to contribute to the stroke support society. Ketan sir, आपका ये help, आपका ये dedication, hats off to that, sir.
Yes. Actually, I'm going for surgery to out of town for Ahmedabad.
अच्छा. Well, शुक्रिया बहुत केतन साहब to join in.
Thank you, Sodhi sir. Thank you.
Welcome all. I mean, we are very happy to have Mr. Hardeep Sodhi, Stroke Support India के founder, director. और हर बार की तरह sir, I truly respect and appreciate your dedication and devotion for the stroke patients and the families of stroke affected, sir. Namaste.
Namaste, Chirag.
And Dr. Ketan Patel, leading neurosurgeon from the city of Ahmedabad, always ready to contribute whenever he is asked for any awareness on any related neurological disorders. Dr. Ketan Patel, namaste.
Thank you, Chirag bhai. Thank you.
Hardeep Sodhi sir, स्ट्रोक सपोर्ट इंडिया पेशेंट सपोर्ट कम्युनिटी की अच्छी एक्टिविटीज के बारे में we have said it many times. So, sir, you are already a co-host. If you can share the screen and quickly take us through the activities done by the NGO, sir.
Stroke Support India पेशेंट सपोर्ट ग्रुप है इंडिया में. हम मरीजों की आवाज हैं. बेसिकली we interact to encourage, to share inputs, to talk about various treatment possibilities, etc. प्राइमरली मरीजों की तरफ से. हालांकि हमारे ग्रुप पे डॉक्टर्स भी हैं, फिजियोथेरेपिस्ट भी हैं. दे प्रोवाइड वेरियस इनपुट्स. तो हमारे दो मिशन है स्ट्रोक सपोर्ट इंडिया के. एक तो बेसिकली रेजिंग स्ट्रोक अवेयरनेस एंड सेकंड इज सपोर्टिंग स्ट्रोक सर्वाइवर्स एंड देयर फैमिलीज अक्रॉस इंडिया. वर्ल्ड स्ट्रोक ऑर्गेनाइजेशन से हमें रिकॉग्निशन मिली हुई है. वी आर वन ऑफ द लीडिंग स्ट्रोक सपोर्ट ग्रुप इन इंडिया एंड वी आर पार्ट ऑफ एन एनजीओ कॉल्ड नवानुभूति वेलफेयर व्हिच इज एसेंशियली working in various areas: sustainable development, environment, capacity upgradation, including a major portion is health related matters where Stroke Support India is a prominent player. तो हमारे WhatsApp ग्रुप भी हैं, मोबाइल ग्रुप, टेलीग्राम भी है, सोशल मीडिया चैनल्स भी हैं. WhatsApp ग्रुप इज ऑलमोस्ट, in fact it is at capacity. हमारा टेलीग्राम ग्रुप अब ज्यादा वहाँ हम मेंबर्स को ऐड कर रहे हैं और कोई भी स्ट्रोक इफेक्टेड, उनके परिवार वाले या स्ट्रोक एक्सपर्ट्स, डॉक्टर्स, फिजियोथेरेपिस्ट कहीं भी हमारे टेलीग्राम या व्हाट्सएप ग्रुप पे ये लिंक यहाँ दिया गया है strokesupport.in/add. इसको इस्तेमाल करते हुए या फिर यहाँ पे स्लाइड पे QR कोड भी होगा, उसको लेते हुए, और या फिर सिंपली 9810290988 मेरा नंबर है, मेरे को यहाँ व्हाट्सएप करेंगे तो आई विल रिवर्ट बैक टू देम किस तरीके से वो ग्रुप में ऐड हो सकते हैं. अदरवाइज ये हमारे कॉन्टैक्ट पॉइंट्स हैं. stropeindia@gmail.com ईमेल आईडी है. मोबाइल मैंने अभी बताई था 9810290988 और हमारी वेबसाइट है https://strokesupport.in. तो ये छोटा सा हमारा इंट्रोडक्शन है साहब. और जैसे मैंने हियर द पेशेंट्स वॉइस एंड वी इंटरेक्ट विद एक्सपर्ट्स जैसे डॉक्टर केतन, आप very kind to come on this program to share your experience, to share your inputs. We keep on interacting and we hope to interact with you as well and hear and learn from your experience as well. So thank you.
Yes.
I will stop sharing now. This is a short introduction to Stroke Support.
Thank you, Sodhiba.
तो जैसा हम आज टॉपिक हम देख रहे हैं, we are going to discuss, डॉक्टर साहब, दो उसमें मेरे को एस्पेक्ट्स नजर आते हैं. एक तो काफी बड़ा डिलेमा होता है पेशेंट्स के, मरीजों के दिमाग में जब स्ट्रोक की बात पहली बात पता चलती है कि क्या सर्जरी जरूरी है, क्या सर्जरी करानी चाहिए, क्या मेडिसिन से काम चल सकता है. तो पहला तो क्वेश्चन ये है डॉक्टर साहब, अगर मान लीजिए स्ट्रोक के सिम्टम्स आए और स्ट्रोक डायग्नोस हो गया है, so under what circumstances व्हाट आर द चॉइसेस कि पेशेंट को कई बार तो इमरजेंसी होती है, चॉइस रहती नहीं है, बट लेट अस से कि चॉइस है, तो उस समय व्हाट आर द पैरामीटर्स टू बी कंसीडर्ड कि भी मेडिसिन पर ही रहें कि सर्जरी कराएं? तो इस बारे में डॉक्टर साहब आपके व्यूज क्या हैं, एक्सपीरियंस क्या है?
Normally, the treatment of stroke is both medical and surgical. In this also there is a two parts. One is acute stroke management, and second is the surgery to prevent the secondary stroke. Means once stroke occur, now in future, if stroke is not occur, for that we have to do surgeries. So there's a two type of management: acute stroke management and secondary stroke management. Acute stroke management, normally the treatment of choice is depending on the what are the symptoms, what are the CT scan finding, MRI findings, what is the patient age, which are the other comorbidities there. So generally, those patients who are have a TIA or mini stroke, for that only require the medical management. But those who patient present with larger stroke, in sense patient having a symptom of facial weakness, paralysis, one side of the body, and the CT scan or MRI finding showing that there is a large vessel occlusion. The main thing for the surgical intervention is there is a large vessel occlusion. Means if there is a MC occlusion or IC occlusion in this patient, or patient came with a window period, means the patient came in within a 6 hour, and nowadays the guideline extended up to the 24-hour, particular in individual cases, but the main guideline is for 6 hours. So if patient reach within a window period and patient having large vessel occlusion, so this patient require the surgical endovascular treatment, and those patients get more benefit from the surgical aspect. Those who are the smaller occlusion or distal vessel occlusion, or there is a minor stroke, then those patients is generally require the medical management. So this is a acute stroke management protocol. The main question is occur when once a stroke occur. So in future, how to prevent the second stroke? So normally the stroke occur from two areas. One is cardioembolic stroke. Second is a thromboembolic stroke. Means one is any small emboli coming out of the heart and go to the brain and lead to the cardioembolic stroke. Second is the atherosclerotic changes goes to the brain and lead to the stroke. So in this, if the patient has developed recurrent stroke, means more than once, 2 times, 3 times, in this patient we have gone for the evaluation by the carotid Dopplers to echo angiography, and if we found that if there is a patient having the carotid artery stenosis, particularly for the neurosurgeon point of view or neurologist point of view, because our main target is carotid. So because the cardiac point of view managed by the cardiovascular surgeon. So in carotid and blockage is there, particularly symptomatic patient have more than 70% occlusion. In this case, patient required the surgery. So this type of surgery include the two type of surgery. One is CEA, the open surgery, carotid endarterectomy. Second is CAS, carotid carotid artery stenting. So these two type of surgery we will normally doing to prevent the secondary stroke. One is open, one is endovascular. So these are the surgical aspect.
मैं थोड़ा सा आप समझने की कोशिश करूंगा जो अभी तक आपने बोला इन लेमैन्स वाइज, जैसे कि मैंने बोला पेशेंट के तरीके से। तो एक तो है ट्रांजिएंट इस्केमिक स्ट्रोक, जो कि जिसमें स्ट्रोक का सिम्टम आया, थोड़ी देर रहा, लेकिन फिर उसके बाद आदमी नॉर्मल हो गया।
यस,
कि मैंने समझा नॉर्मली दो सिचुएशंस, अगर डायग्नोसिस के बाद लगता है कि मेडिसिनल ट्रीटमेंट से ही अभी गुजारा हो सकता है, then surgery may not be the option at that time. लेकिन अगर जैसे आप कह रहे हैं लार्ज वेसल ऑक्लूजन, जिससे कि एक ब्रेन का कोई बड़ा आर्टरी के अंदर या कहीं पर आप देख रहे हैं कि कोई
ब्लॉकेज है,
जो कि बड़ा है, जैसे आपने शायद इंडिकेट किया कि 70% से ज्यादा दैट एमसीए जो कि मेन सेरेब्रल आर्टरी है या आईसीए वो ब्लॉकेज है उसके अंदर, then perhaps surgery will be the option that may be a preferred option at that time, जो आप कह रहे हैं आप करें। लेकिन एक कहा कि emboli is basically, what is emboli? These are blood clots which are traveling?
Yes, these are the blood clots containing the cholesterol matter, platelets. These are the things that made the clots.
So emboli, जैसे आपने बोला, it can travel from the heart, मतलब कि उसका जो प्रोडक्शन पॉइंट है वो हार्ट में है, but via the bloodstream it has gone up to the brain.
Yes,
so, will be a matter which will perhaps be addressed by a heart specialist.
If this cardioembolic stroke occur due to the cardiac problems. So if patient having AF or arrhythmias or some valvular disease, that lead to the vegetation in the heart, and from that vegetation some release from the heart and reach to the brain, and they lead to the cardioembolic stroke. So these are the stroke or shower stroke, means they are normally affect the brain part in a different location, not a large vessel occlusion or single vessel occlusion. So I have seen two type of surgery. We have to first understand what is a acute stroke management surgeries and what is a surgery which required to prevent the second stroke. These are the different things.
Okay.
Acute stroke management surgeries means a patient came right now with a stroke symptom. This patient managed by medically as well as surgically. So that is the acute stroke management normally. And in this, the required the surgery name is a mechanical thrombectomy per se. This is the endovascular treatment. In this, those vessels who occlude like MCO occlusion or ICO occlusion, so we do the thrombolysis and we open that occlusion. So that is called acute stroke management. It is normally done in the window period of 6 hours when patient came within the 6 hours of arise of symptoms. And this window period may be extended up to 12 hours or maximum 24 hours. That may be individualized depending on what patient is required or what get benefit, because the time window period is already gone. So these are individual cases. But within a 6 hours, a patient of stroke will come to the hospital, and where the patient require, we have done the angio, and it suggests that there is a large vessel occlusion. In this case, if patient went to those hospitals where the endovascular thrombectomy, means mechanical thrombectomy is possibility, then this patient require get the most benefit. So this is acute stroke management treatment. What is the secondary stroke management means? This patient, when the acute stroke management is already done by medically or surgically, whatever, and patient survive, after the acute period is over, after 1 month or 2 months or 3 months, we will normally at the time of a stroke, we have already evaluated by the Doppler or angiography, and which suggests that the patient having carotid blockage in the neck. So when there is a after 1 month, when the acute stroke management is over, patient is totally recovered or whatever extent is recovered, now we again evaluate and we will see where is the what about that blockage of carotid artery. And if there is a blockage is more than 70% and patient having symptom, already symptomatic stroke with 70% blockage, now then this patient is now also a chance to get a secondary stroke. Okay. So now to prevent secondary stroke, there are the different surgeries. In this, there are two types of surgery. One is open surgery, where we open the carotid, we remove the plaque and close it. Or second is same like endovascular, where we go in the blockage area of carotid, where we expand, means we do angioplasty and then we put the stent to remain the lumen patent. So these are the two different type of surgery to prevent the secondary stroke. Okay. So both are things are different. Acute stroke management surgeries are different. Secondary stroke management surgery are different. So these are the two type of different surgeries.
ठीक है, आई गॉट द पॉइंट, मैं समझ रहा हूँ। एक तो आपने बोला एक्यूट, जबकि इमरजेंसी सिचुएशन है,
Yes, yes.
have to evaluate and you have to manage it either by mechanical thrombolysis,
Mechanical, yes, or medicine,
or
or TPA. Yes,
medicine.
yes, yes, sir.
But उसके बाद जब patient stable हो गया है, you will do
Yes,
diagnosis and analysis and then take a further call कि अब क्या करना है to prevent a second stroke happening.
yes, definitely. Yes, yes.
One is आपने बोला endarterectomy कि जो
Yeah, CA.
CA जो प्लाक है उसको निकाल ही दिया, kind of scoop off कर दिया.
Yes, yes.
दूसरा है जो आप कह रहे हैं that is
Stenting.
stenting.
Angioplasty with stenting. Yeah.
Angioplasty की तरह ही है, where you insert a stent, which
Stent.
presses against the artery and opens up the
Open it. Yes.
That is, these are the
lead to the ultimate goal of both surgeries to give the proper blood flow to the brain.
Correct.
And that remove that atherosclerotic clot material. So the small embolic things which release from that clot and again do not go to the brain.
Correct. I think I get the clarity that you are putting forward. तो normally डॉक्टर साहब जो है जो diagnosis है, it is done for all the patients by जो कि acute मान लिया emergency में आए, by the time
Yes.
from the hospital, once they are stable, they would normally know what is the status and what are the next steps. उनको बता दिए जाते हैं.
Yes, all patient. We always evaluate all patient of stroke to prevent the second stroke. So we always do the carotid Doppler and angiography. And when we see what is the stenosis area, means what is the occlusion status. If the occlusion is 10%, 20%, 30%, then we continue the medical management. But the patient having significant occlusion, means 70% according to the guideline. If patient having 70% occlusion, then this patient we offered surgery, this two type of surgery to prevent the secondary stroke. Patient is already taking medicine, that is okay. But we can offer if you have a significant blockage, so you have the more chance to again the stroke as compared to those patients who have a very small blockage or those who are normal people. So we can give the information to that people or matlab stroke patient that if you have a significant occlusion, so if again stroke, your probability for the second stroke is very high.
That's what I'm wrong.
So if you want to reduce that probability, or if you want to reduce because normally first stroke sometime occur TIE or mini stroke, the second stroke is large normally. So every time stroke become larger. So it is better to prevent the second stroke if patient having the significant occlusion. So we always offer.
So just as out of curiosity, generally ऐसा भी आपने देखा है, what is a rough percentage कि acute management तो हो गया, लेकिन उसके बाद after diagnosis surgery की जरूरत नहीं पड़ी? Let's say ऐसे
yes,
roughly.
More patient, more means the surgical patient is always less because normally those patients who have 70% occlusion or the disease area occlusion only 10%, 20%, then we remain continue the for surgical management. It's more as compared to surgical aspect.
Okay.
Definitely medical management is more.
तो ऐसा मैंने वैसे कई बार ही देखा है
and normally
हाँ जी
normally when we evaluate this surgery CE or CAS, he usually prevent the recurrent stroke. So normally patient at the time not understand sometimes patient required surgery to prevent second stroke, but when patient occur the recurrent stroke, then they understand now I will require the surgery to prevent the recurrent strokes. So generally this surgery offer for recurrent stroke.
ठीक है. Just to take it further, डॉक्टर साहब, दूसरी तरीके की स्ट्रोक भी होती है, हेमरेजिक स्ट्रोक भी होती है.
Yes.
उसके अंदर भी ये ऑप्शंस या ये डायग्नोसिस
नहीं, no, that is a different entity. That is a totally different entity. We are talking right now about ischemic stroke. where there is a vessel occlusion. Hemorrhagic stroke is the rupture of vessels which lead to the hemorrhage, hematoma in the brain, and further consequences. In that scenario, there is only acute management. Normally, there is a acute stroke management. There is no further stroke management. Yes, we have to control the parameter like diabetes, blood pressure, if smoking is there or cholesterol is there. In the both the stroke, we have to control all these parameters to prevent the further stroke. But as such, like a CE or CAS in ischemic stroke, there is no surgery to prevent the recurrent hemorrhagic stroke. But in hemorrhagic stroke, acute stroke management is more important, because in hemorrhagic stroke, majority of patients require the surgery, open cranial surgery, as a life-saving surgery for the primary acute stroke management. So hemorrhagic stroke is totally different entity.
Okay, I understand. So
there is no endovascular management for the hemorrhagic stroke.
Okay, okay. तो जहां तक इन सर्जिकल प्रोसीजर्स का सवाल है, are there specific hospitals with specific facilities, or
yes,
what
yes,
facilities would the hospital?
Yes, this endovascular mechanical thrombectomy or the CAS means, and all endovascular procedure done under the cath lab. So those hospitals have a facility of cath lab. That is only possible that acute stroke management or the carotid artery stenting. And that cath lab is always not available in every hospital because it's a very costly instrument. But yes, in hemorrhagic stroke, we can this management can be done by the hospital where the ICU setup is there and the facility of neurosurgeon and neurophysician is there. So those hospitals who have a facility of neurosurgeon and neurophysician with good ICU setup and a good cath lab where we can done everything. But otherwise, those hospitals do not have a cath lab, but a neurosurgeon, neurophysician available. Then we can manage as a medical management of stroke as well as the open surgery like open brain surgery or open CEA. That is can be manageable. So each and every hospital is not occupied with, equipped with the cath labs. So it is not possible in every hospital.
And between carotid artery stenting and endarterectomy, what is abhi kya trend hai? As jahan tak mere ko
initially there is a initially CEA is preferred. Once the endovascular treatment is came, the over a period of time the people are more preferring CAS also. But these are the things are individuality, because we have to see the different parameter. So what is a patient age, what is which are the other comorbid condition, what is a vessel status, what is a soft plug, hard plug, what is the atherosclerotic stenosis. So in this case it is an individual decision. Both procedure is good. Both procedure have their own advantage as well as disadvantage. Both procedure are good, but now trend is on endovascular. Gradually the trend is going on endovascular because it is not open surgery done by the only femoral puncture or radial puncture, so it's a suture-less surgery. So now the recovery is also good, same as CEA, and the complication rate also both procedure have their own complication and advantage, right? But the trend is basically nowadays is CAS, means endovascular.
Okay, because as you said, maybe it is a faster recovery period operation.
Yes, because it is not open surgery, so suture-less surgery, yes. So it's a faster recovery period. So people are more preferring the CAS.
What about the cost angle, sir? Very broadly between the two.
Broad CAS maybe around 1.5 to 2.5, or depending on the corporate hospital, maybe up to 4, up to like this. And same as CEA also cost is around 2 to 3, or around depending on the hospital. Actually, the costs mainly prefer on the which doctors are doing and where the facility, which hospitals. Those are corporate hospitals, the price is very high. Those who are medium hospital, the price is little bit low. On an average is from 1.5 to 3.5 to 4, depending on the circumstances.
Okay. And अगर हम कैश की बात करें, उसमें जो स्टेंट्स होते हैं, they are pretty industry standard. Are there different varieties of stents also?
Yeah, it is a open stent, closed stent. These are the different varieties. Now there is a advancement in also gadget also. So stents or balloons. In this there is also the big advancement is there already. Is going on. The quality of stent is improving day by day. Price is also day by day. Capping is there also. Catheter, micro catheter, guide wire. All these things are day by day improving. Day by day more disease specific. So it is very good for these are the people. But CAS or endovascular treatment is mainly based on the gadgets, because it is a totally gadget dependent things, because it is always from start to end we are mainly based dependent on the gadgets. I mean catheters, coils, stenting, stent retriever, stents, balloon. So it is mainly
right. ठीक. Fine, Dr. Saab, thank you very much. आपने काफी अच्छे explain किया. To a layman like us, I'm sure it will be helpful to know कि क्या possibilities हैं, क्या options हैं. So
thank you Hardeep bhai, thank you.
केतन साहब, बहुत अच्छा लगा आपसे बात करके.
श्योर, मुझे भी बहुत अच्छा लगा. और आप जो कर रहे हो that is the best thing, कि आप जितना मतलब I have not heard before, because मतलब in I don't know why, but this is a best thing you have done, that Stroke Support India groups, and you are educating the stroke patients, giving the information about management and like this, all the information. So it is a very best moment, I think. So it is a very best moment. I wish more and more stroke patients will join this our Stroke Support India group and get the most and most benefit.
Thank you. शुक्रिया बहुत साहब. हमारा भी effort यही है to raise awareness, ताकि जो भी affected है उनको benefit हो सके. Thank you very much.
Thank you.
डॉक्टर केतन पटेल सर, हरदीप सोधी सर का इमोशन स्ट्रोक सपोर्ट इंडिया के साथ जुड़ा हुआ है. एंड ये जो आपने एक अच्छी बात छेड़ दी कि ही हैज डन सम अमेजिंग वर्क पेशेंट्स के लिए. सोधी साहब ने अपने पिताजी को स्ट्रोक से खोया है, तो उनका इमोशन स्ट्रोक पीड़ित पेशेंट और परिवार को हेल्प करना है. तो
नहीं, सही है.
उसके लिए उनके बिहाफ पर और कैडिला के बिहाफ पर मैं आपको रिक्वेस्ट करता हूं कि उनका एक पोस्टर है स्ट्रोक पेशेंट कम्युनिटी रिलेटेड, वो हम आपको दे जाएंगे. एंड वी रिक्वेस्ट यू कि अगर आप अपने पेशेंट्स को बताएं कि ये स्ट्रोक सपोर्ट
को डेफिनेटली आई विल से
फायदा है, तो पूरे भारत से स्ट्रोक पेशेंट्स की बड़ी हेल्प हो जाएगी.
श्योर
सो मच.
डेफिनेटली.
सोधी साहब,
थैंक यू चिराग भाई, थैंक यू सोधी साहब, थैंक यू. नमस्कार.